Σας ευχαριστώ. Αυτό δεν θα μείνει εδώ μάλλον, θα το βάλω. Σας έφερα κάτι βιβλίο. Ευχαριστώ πάρα πολύ για την πρόσκληση. Είμαι όντως Έλληνο-Καναδέζα. Τα ελληνικά μου είναι καλά, αλλά θα σας μιλήσω σήμερα στα αγγλικά. Πρέπει να πω ότι είναι ένα θέμα που έχω πάρα πολύ πάθος. Έχω μεγαλώσει στο Καναδά που δεν έχουμε το ίδιο πρόβλημα, ευτυχώς. Έχω προλάβει όμως όλους τους νόμους, όλους τους τσακωμούς που περιμένουμε να γίνουμε εδώ στο Καναδά. Ήμουν μικρή βέβαια, αλλά σπούδαζα τότε και ήμουνα δίπλα σε κάποιους γιατρούς κάποιους πολιτικούς που κάνανε τη δουλειά, γιατί έπρεπε να γίνει και μπορεί να γίνει εδώ. Και δεν ήταν εύκολο, που έχει γίνει, δεν ήταν εύκολο. Έχω ακούσει για σπίτια που έχουν διαλύσει με αυγά, με αστυνομικούς που είχαν φωνάξει. Ήταν από τις πρώτες χώρες ο Καναδάς που εφαρμογίστηκε το νόμο. Αλλά δεν θα σας μιλήσω γι' αυτό, θα μιλήσω για το διακοπή καπνίσματος και πάω στα αγγλικά τώρα. My co-speakers have said it very, very well with lots of passion. Both of you, thank you. I want to very, very briefly just emphasize there is nothing more important than we can do for Greece than to help people who smoke quit, bar none. We have reached epidemic proportions for years now. It is the leading cause of death and disability. We can calculate all sorts of numbers. They're very, very clear. Nothing more important. Massive personal, social, economic burdens have been caused by this very deadly product. And to say the least of all of that, these are our families, our children, our friends, our loved ones that we're talking about. Like you, I'm a mother of a young son that every day goes into a space where they breathe in smoke. The numbers are clear, they're staggering. They're not more than Canada, actually. We still have more smokers to date, but they are staggering and they warrant a very, very serious effort from the public health community, of which I consider myself. I work in Europe, in Canada, and now here in Greece on the issue of smoking cessation. And it's one that we have lots of evidence, lots of best practices, but it really does take a lot of effort to get things done the right way. And the rigor and the science that goes behind what we do is all present. It's a matter of action after that. The costs have already been spoken to. These are the system costs just to the hospital-based system. And I have a management background and worked in Canada for years calculating all of the benefits of cessation over and over again. And as we present them to governments and CEOs, they said, yes, we're going to invest. This will save money. So a smart system will take action on this. So quitting is a process. We know it well. It is certainly not easy. Someone smokes, they make a quit attempt. Hopefully they're abstinent, but oftentimes they go back to smoking and it needs to be repeated again. There are certain individual factors that affect whether we're successful, whether we want to quit. It's from genetics all the way to where we live and how much money we make. Tobacco control policies, and that's why it's come into our conversation today, play a big role of whether people want to quit, how much they smoke per day, whether they're motivated to. And likewise, brief interventions are required so that people who are not making the effort to quit do so more frequently and with greater success. Vicky Katsauna has already spoken to smoking cessation treatment, so I won't dwell on that ensure that people who are trying to quit stay quit for as long as they can and hopefully for years. The truth is, and Vicky said it, at the end of the 1 year, 5% of people who quit without support will go back to smoking. We don't want them to do that. We want them to do just the opposite. The issue, of course, it's an addiction, a very, very tenacious addiction that is plaguing our community. We do have evidence-based therapies. They're very clearly laid out, and we have many people trained, not only here in Greece, but they're training people outside of Greece in best practices. Vicky is one of those, but there are many, many people who I know are spending time outside of Greece training physicians rather than in Greece. Pharmacotherapy, behavioral support, it's already been said. If I would have seen the other presentations, I think I would have skipped through this. But we can certainly increase the likelihood of someone who tries to quit in being successful. We can get them to 1 in 2 of every smokers to be able to quit, a 50% chance of quitting if we do it in the right way. So designing a system that allows a smoker to do it in the right way so they are most successful, I think, is one of the questions that we all have working in tobacco control. It's probably a little bit advanced in the sense for Greece we've got more basic issues, but population health impact. We're all here at the Pan-Hellenic Public Health Conference, and so population health impact is what we're after. Reach and efficacy. It's the formula of Glasgow. There's more after that. But how do we get greater reach, and how do we ensure that people are using evidence-based, efficacious therapies? The first, and I think one of the biggest issues, is not enough of our Greek residents are making quit attempts. 12% in the last 12 months have tried to quit smoking, is what the data says. 2017 data from the Eurobarometer. 44% in their lifetime. When I saw these numbers, and maybe to you they don't stand out, I said, I don't believe it. Almost every smoker in Canada has made a quit attempt in their lifetime. Most of them have made many. And in any given year, a smoker in Canada makes at least one quit attempt. 70%. They're regularly trying. The addiction is what's holding them back. We've got heavily addicted smokers left that are continuing to use that. That's not what's happening here, though. People are not making an attempt to quit smoking. We asked, in Crete, we're running a trial there, and we asked residents around, that were entering primary care whether or not they wanted to quit smoking, and here's the response. 25% would be interested in the next 30 days. They were thinking about it and wanting to do so. Another 40% or so are thinking in the next 6 months. There's a group that are at a tipping point where we can really get involved in supporting them. 65% in total were thinking about quitting at some point in the very near future, and the remainder were not. So they're thinking about quitting, but then they don't make the quit attempt. Very important story to tell. So our challenge then is to increase the number of people making a quit attempt on a regular basis. And hopefully, and it'll be our job then to couple evidence-based therapies that Vicky spoke about earlier. It's an issue then of supply and demand. What do I mean by that? On the demand side, in order to get someone to quit more regularly, there's going to need to be triggers in the environment. Healthcare professionals, I will show you in a moment, have a very powerful role to play in that. And we have not activated the healthcare community. Smoke-free workplaces where support is being provided to at least not smoke at work, but if you'd like to quit smoking. Our schools, our hospitals, our government facilities are opportunities. And here is there when smoke-free policies. Why would I want to quit smoking when it becomes inconvenient and too expensive to do so? I have to go outside, I can't sit at το καφενείο και να καπνίσω αυτόματα πλέον. Πρέπει να το σκεφτώ, να σηκωθώ, να πάω έξω. Αρχίζει και σκέφτομαι ότι μήπως πρέπει να το κόψω. Έρχεται ο κόστος 10 ευρώ το τσιγάρο, που είναι 4 τώρα. Καναδά είναι 10. Πόσο άλλο να πάει αυτό? Ο γιατρός μου είπε, δεν πάει άλλο κυρία Παπαδάκη, πρέπει να το κόψετε. Έχουμε η μαμά που μόλις γέννησε και που λέει μήπως πρέπει να υπάρχουν αυτές τις στιγμές, triggers in the environment to get people thinking about quitting more frequently so they take action. And of course, direct-to-public campaigns, which were a big part of the success in Canada. We unfortunately had Heather Crow, a woman who never smoked but died of lung cancer due to the smoke in her work environment, offer the television cameras in her home for a period of several years, and Canadians, myself included, as a child, we watched her die on television. And she shared with us that experience. Everybody from ages 12 up in Canada remembers this particular woman. She was brave enough to do that. But that was a direct-to-public campaign, and it really hit home with a lot of people. These are the interventions, and of course, school prevention. We need to get into our schools. Our teachers are smoking. Our kids are smoking. They're starting very, very young. It's not the only solution, but it's part of ensuring that the demand for cessation services and the demand for using tobacco products decreases. On the supply side, what will we bring then for people who say, okay, I'm ready to quit then. You've inspired me, you've motivated me. We need highly trained healthcare professionals. We need every time you go to a hospital for someone to ask you if you're smoking and to say, we can help you quit if you're ready to do so before you leave today. This is what we do now in Canada. Quit smoking clinics that our colleagues in the field of pulmonology, and it's the leadership I've seen from the respirologists, we call them the pulmonologists, in Greece, is incredible. to support them in doing the work that they can so that they can see patients with increased complexity and complement the rest of the healthcare system. Access to medications. It's wonderful that there's coverage in Greece for all of these medications, but smoking, the first-line therapies, the leading cause of death and disability that are evidence-based, highly cost-effective, Vicky said it, are not being covered. And of course, specialized services for people who are in high-risk groups. A high-risk group is a pregnant woman who continues to smoke during her pregnancy. We need specialized programs in the obstetricians and gynecologist clinics so that that doesn't go past the first trimester. I'll move on. I'd like to just say a few words around clinical leadership because it's the area in which I've been working in. I am not a clinician, I'm actually a public health specialist, and I work hand in glove every day in my career in Canada with clinicians, helping them figure out how to identify processes, build better training programs, and then deliver them within our healthcare system. What I've observed is when we activate the medical community, when leaders, physicians, nurses say it's enough now and we're going to do something different, great things happen. Things start to change. The role of health professionals is a big one. In our community, people listen to their physicians, to their nurses, in particular when there is a smoking-related illness, and they are much more motivated to make a quit attempt when someone advises them from within the healthcare system. Healthcare professionals can also link to specialists to offer support and on an ongoing basis check in because there's a relationship that's been established. When we ask smokers who plays the most important role in their decision to quit smoking, health professionals is at the top of the list. It's a very important group to activate. Vicky showed you this slide, but there's ample reason why a healthcare professional would spend time on this topic of cessation. It's the best use of your time, the most important clinical intervention. Let me tell you about the Titan Crete project and the larger project Titan Greece and Cyprus. It's a project of Professor Leonis at the University of Crete. We began it when I was in Canada a few years ago. It is a sister project to a Canadian initiative in the primary care and the hospital settings that has grown nationally in Canada. And we've been able to receive a couple of grants to allow it to be pilot tested in Crete, and now it's growing to across Greece. And we're working on it in partnership with Vicky Katsiouna, Kyria Mitrouska, Kyria Pataka, It's a partnership between all of the medical schools in Greece to train the primary care physicians in evidence-based practice of smoking cessation. Here are the areas in which we've either been or going to, and our goal is to get to 300 primary care physicians with training this year. We started in October and we've already reached just around that number of 300, and we still have many sessions to go. There has been an incredible response from the primary care community. They're engaged, they want to learn more, they want to help their patients, they want more training after we finish our one day with them. And yesterday I spoke to a group of 160 medical students at the University of Crete, and I was so excited to see the response from them too, around how interested they are in taking this issue very seriously. Here are some pictures from our training sessions so far: Iraklion, Thessaloniki, Chania, and we've got a few more to go. I was asked by Professor Bechrakis to not forget to inform you that Greece has played a big leadership role in the 2017 European Smoking Cessation Guideline, NODIGO, με 80 recommendations around evidence-based practice for smoking cessation. It's a great book. It summarizes everything you need to know, and we base our training to primary care physicians on this guideline. It has a sister book, τα έφερα εδώ αν θέλει κανείς να τα δει. They're all available in English και γίνεται μια μετάφραση τώρα, νομίζω είναι έτοιμος και όλας. These are for high-risk populations. It warrants special attention. There are different treatment strategies for adolescents, pregnant women, those with cardiovascular, diabetes, and COPD. The editor of this particular document is Kyria Bechrakis, Panagiotis Bechrakis, and I think it's good on all of us to see the European leadership being provided around the development of these guidelines. We've also created some tools so that from a management perspective, there are processes in place so that healthcare professionals can bring tobacco treatment. We've created some videos to demonstrate what things look like for clinicians. And we've tested in the form of a trial our uptake. And we've seen when we started our program that knowledge is very low in the healthcare professional community around evidence-based practices, what we know in the tobacco treatment guidelines to be the best practices. Following a one-day training, 6 hours, you see them up to 100%. Very easy to make those changes in evidence-based practice. The reason they're low in the first place is because it's not covered in medical school. It's a very easy thing to do, right? To invest 6 hours in this very important topic. The changes are there. And then what happens afterwards? They bring them back to their clinics with enthusiasm, and we see changes in the 5 A's that Vicky talked about earlier, in asking and advising. That goes from 30% as far as assistance up above 65%. Still more work to be done there, but immediate changes then in practice following a 6-hour training and some tools. There's a website if anyone's interested. I want to close by talking a little bit about public health policy. There's all sorts of reasons for smoke-free laws and taxation to go forward to protect citizens. But from the perspective of smoking cessation, it is a motivation. Almost every smoker will tell you, while I enjoy smoking in the coffee shops, στο καφενείο, όπου να είναι, στους γάμους, με βολεύει, θα μπορούσα να πάω έξω. Θα μπορούσα. Δεν είναι τίποτα. Απλά αφού όλοι καπνίζουν, θα καπνίσω κι εγώ. I would like for there to be a law passed so that I have to go outside. Θα μου μειώσει και εμένα το κάπνισμα. Όλοι το θέλουμε, τελικά. Θα μας κάνουν όλοι καλό. It's a very important part of a smoking cessation strategy to look at the demand side, to look at the policy side, how we can support it. Every time we go and deliver a training session, I think, Vicky, you know it very well too, the physicians say to us, what's going to happen then? We do all of this effort, and the policy is not there to cover it. So these are the things that need to change. Very, very quickly, for those of you who are interested, the province of Ontario in Canada has just released their smoking cessation strategy for the next 5 years, and it's very, very good. It's worth looking at it. It's worth us having a careful look to see what can be drawn. Greece is not Canada, that's for sure. But why not make it our own and learn from others? The strategy talks about helping people quit smoking. It talks about protection, and it talks about youth. Here it is laid out. I don't want to go into the details because I don't think time permits, but certainly they're talking a lot about motivating more quit attempts, getting the healthcare system activated, all sorts of calculations around how we can get reduction in smoking, and that you can see here it's multiple interventions, not just one that are going to make the difference. No one approach strategy. They have to be combined to work well. My institute at the Ottawa Heart Institute is part of the provincial strategy. They continue to work on a daily basis around something called the Ottawa Model. We've brought it in Titan Crete, but it's actually born inside of a hospital where every time you would enter hospital, and these are all the hospitals across Canada, there are now 300 delivering evidence-based smoking cessation. It goes on the table of the CEO. How many smokers left the hospital without being spoken to about cessation? Did they receive the medication before they left? Is everyone trained in smoking cessation? This is what's happening in Canada, and I wonder if it could happen here, something to that effect. It's all evidence-based, it's been published, it's there for us to read. I heard a plan for cessation, I heard it in your slide. I have the exact same 5 or 6 things that would need to be done here in Greece. I won't dwell on them because I think they've been spoken to, and I'll thank you very much for the opportunity to be here.